Okay, everybody, welcome to the session. I'd like to just give you a few little housekeeping things. This session will run until 5 o'clock. We'll bring that to a formal end, and then we'll probably stay around for another 5 or 10 minutes afterwards in case people have got lingering questions. But we'll aim to wrap it up in an hour. The session will begin with myself as a short introduction, and then I'll be interviewing our panelists. First of all, we have Research Associate Juliette Podgy, Dr. Chris Suby, a consultant in acute medicine at Ysbyty Gwynedd in Bangor in North Wales, and Dr. Lena Chirich, who is a microbiologist at University College London. So I'd like to begin by just sharing a little bit about who we are, what we do, and then I'll get into the meat of the design in a pandemic session. So my name is Jonathan West. I'm a reader in healthcare design. I lead the healthcare work at the Helen Hamlyn Centre for Design at the Royal College of Art. And for those that don't know the Helen Hamlyn Centre for Design, we're based at the Royal College of Art. The Royal College of Art is the world's only wholly postgraduate institute of art and design. And the Helen Hamlyn Centre for Design takes graduates from the Royal College of Art and puts them on funded research projects. So by private companies, Research Council funded, or charity third sector projects as well. And we've been doing inclusive design work for nearly 30 years, and I've been leading the healthcare work. I've been working at the centre now for 16 years. So we've been doing a lot of work in healthcare, and we've been very fortunate to work with lots of very talented designers of all different stripes. So architects, product designers, information experience designers, and so on. And we've also been very blessed and fortunate to work with a number of really, really great clinical partners and research partners. Every project that we do is done with frontline clinicians working on hospitals, or maybe with GPs or in patients' homes, or in the lab, and so on and so forth. We've spanned many, many different environments in our research, and our outputs have included product designs, devices, information, service designs, and environments as well. When COVID hit in mid-March, I'm sure everyone will remember the mood in the nation at the time, but all our regular work was put on ice because a lot of our clinical partners were otherwise engaged, obviously, in the fight against COVID. And you might recall there was a real fear. We'd all seen what was happening in Italy and the intensive care units being overrun, and people were genuinely offering their services to help help this country sort of fight against the coming first wave as we saw it. You might recall the Nightingale's hospitals being built with the help of the military, ventilators being designed and built in rapid timeframes by Dyson and other designers. And a lot of our contacts in the design community were heavily involved in PPE supply as well. And one of the most interesting things initially at the outset was that the design community responded by doing what it does, which is innovation. So yeah, a lot of that was, I guess the job, the more important job was to have coordination rather than innovation. So lots of people were designing new visors, for example, but the NHS didn't need 10 different designs of visors. It needed one that it knew how to make and it knew was fit for use on the wards. So a lot of our job was coordinating people who wanted to contribute to the effort into meaningful outputs that could be used on the front line. So in addition to doing this, we put out a call to all our research partners, past and present, to see how we could help, how design could help. And to be honest, in the first week, we didn't really hear very much back. I think a lot of our clinical partners were too busy on the front line. But then bit by bit, people started getting back to us. And actually, whereas I thought a lot of our demands on our time would have been about devices, the vast majority were about graphics and information design, and were very, very quick turnaround projects. So I'd just like to share a few slides with you now about the projects that we were involved in, and then we'll move on to the interviews. So I'll just share the screen now. So the first was for University College London hospitals in North London. So they had a situation where they had repurposed all their theatres on one floor to become a COVID-19 recovery complex. So they'd repurposed and had a new layout or new designs for their rooms on that floor. But they also had a problem of redeployed staff. So a lot of people who were coming to work in that space weren't familiar with the space anyway. And adding on top of that, it was a new layout of space, meant that it was imperative and an urgent need that people understand where equipment was and how they could access it. So this was the first thing that they came to us with. They had a very, very rough sketch map of which rooms would hold what purpose. And then we basically just did the standard iterative design approach, where we were able to refine it, get a hold of blueprints of the building itself, and they sketched onto those what the different zones and different areas would be. And it became quite an interesting microcosm of design and healthcare, because whilst we were doing all these iterations, it was very, very much against the clock. So it's at this point, it's probably worth giving a great word of thanks to our research associates, Juliet, but also Imran Nazarali and Rosanna Trainer, who also worked of their own time over weekends, over the Easter weekend as well, to get the graphic designs done. But yeah, in a microcosm, we did lots of iteration. We got feedback from the front line, but that feedback kept changing because the situation was so fluid. So this is the final version, but it took quite a long time to get agreement from frontline staff where, for example, the defibrillator should go, or where the airways trolleys might go. And it actually came down to a point where we thought, well, if we can't agree on where the different trolleys might go, we just have to say this is where they should go, because any place would be better than no agreed place. So we issued these, and yeah, they ended up being used on the front line. So here's a happy doctor beside their maps, and now they can see where everything is, and a much more streamlined workflow. That was the first project. The second was for Public Health Wales. So you might recall at the time there was a great drive to get the drive-through COVID testing kits finished so that you could get more of the population tested. But at the time they came to us with a complete mishmash of different graphic styles and photos of what the instructions would be to do the test correctly. So the whole thing was not fit for purpose, and it wasn't clear what steps were needed to be used at what time. So Juliet and Imran worked together with the officials of Public Health Wales to produce very clear, very simple guidance on how to use the testing kits. And this was also rolled out in the home mail testing kits as well, and also able to be translated into Welsh, so it's dual language. And the last project, there was a few more, but this is the last one I'll share with you. Was a slightly happier project that Juliet knows more about than I do, but again, University College London hospitals put out a call to us, but they were receiving many, many messages of thanks and support from the local community and grateful patients. So Juliet was able to construct this mural that I'm not sure if they have yet installed, but is going to print on the wards, and that's obviously helping to raise staff morale. So that was a really quick whistle-stop tour, but I'll just stop sharing my screen now and bring the session into exactly 4:10 to introduce Juliet. So Juliet, you worked on these projects. I wonder if you'd just like to give a brief introduction about who you are and how you came to work on this.
So hi everyone. I am a designer and researcher, and I've been working at Allen Hamlin for the last 3 years. I've been working on projects that look at well-being in the work environment and accessible technologies, but my background is in branding and visual communication, and this is why I inputted on those projects in particular. And I also recently joined the Design Age Institute.
Thank you, Julia. So what were your thoughts when COVID first hit?
So part of my family is in Italy. So I was, it hit me a little bit before everyone else in the UK. So I was very much prepared to psychologically to what was coming.
What projects were you involved in?
I was involved on one major project for a client based in Southeast Asia. And of course, due to the circumstances, things were a bit on hold already.
So when you switched your attention to be involved in the COVID projects, what was it like to work on those fast-paced projects?
I personally really enjoyed it, and also it made me feel that I could have an impact on the current situation. So at the time I was looking at what I could have done for my neighborhood, for instance, and being able to be involved in such kind of project really answered what I was looking for.
And do you think that the way in which, aside from the fast pace of the projects, obviously, do you think the way in which you had to work on these projects was different to your regular work?
I think it was probably the same setup, but to a very different speed. And I think because everyone was focused on getting something done that would work, there was no dynamics of power of any sort. Everyone was really focused to the end goal.
Was there anything you thought went particularly well, it worked well during the course of these fast projects?
I think I was amazed that communication was so easy, considering that the people I was working with were way more busy than I was, doing like really important things such as saving lives. So I was really amazed of how easy it was to communicate actually with people that are from completely different background, and they were under such immense pressure.
That's a good point, actually. I hadn't thought about that. Because I know a lot of the struggle in healthcare projects is exactly that, trying to get people to feed back because people are so busy. And yet, during a pandemic, when you think, obviously, people were even more busy because, as we know, the wards were very, very busy. They still took the time to input. Obviously, the design work must have been very important for them, because obviously you can't carry on trying to function efficiently if nobody knows where any of the equipment is. So. Mm. So, okay, well, is there anything you'd like to add to this, Juliet?
No, not really. I think it was to work on this project, really. I'm really glad I took part in this. Thank you for involving me.
Oh, no, well, let's hope we can do more. Well, I'd like to just introduce Chris now. So as I mentioned, Chris is a consultant in acute medicine. Chris, I wonder if you'd like to just say a little bit more about your background and what you do.
Sure. I'm a consultant in acute respiratory and intensive care medicine, and I'm also lecturing at Bangor University. And so I was one of 8 consultants who were supporting the service that was created to look after patients with COVID in Bangor, which is in rural North Wales. So slightly different setting to some of our colleagues, and the slightly different viewpoint that we could kind of see this wave coming very slowly from Italy and then through London and then up the A55, if you wish.
So what was it like on the ward when the cases first started coming in?
Certainly in the first few weeks, people were very, very anxious, and I think rightly so, because there was this unknown condition. We were very unsure whether we were well enough protected, whether we had the right stock, and look, we obviously see a lot of suffering when we go to work. That's normal, but we're normally not the person who will suffer. And this change in perspective that we could, by the nature of our work, get infected, and by people who were very infected at the time that we were seeing them, and that we, or those people that we live with and that we love, that they could get infected and die from this. That's certainly a perspective that has never been there before.
Well, what did that mean for your interaction with the patients then? It must have coloured it somehow.
Oh, very much so. So on the whole, if possible, we try to be close to patients, isn't it? And especially if it's breaking bad news or having difficult conversations, maybe holding hands, or maybe even taking somebody in your arms and giving them a hug. But all that went out, and I remember that, I started to move a bit like a robot. So you had your kit on, and you were always aware of what was around you and what you were touching and what you were trying to avoid to touch, and try to get out of the patient space where the highest risk of infection was, especially if you weren't in a full PPE. And so, yeah, a very, very different emotional interaction.
And how did you see a difference in how patients typically responded? Obviously, it's difficult to test, right? Because you're not going to see, hopefully, you're not going to see too many repeat visitors. But overall, in terms of patient response during the course of regular care versus during a pandemic, obviously there's one element which is I guess the situation. It's a pandemic, we all knew about it, and it's a very frightening thing. But it's also the physical reality of being on the ward. So the ward must have looked very different. And how did that feel for the patients? Did they give you any sort of feedback?
Less verbal feedback, but patients were obviously also very scared. They were scared to come in for the first. So that the invisible patient is really probably the one that still I'm most occupied about. So lots of people who I'm sure had important health problems just didn't turn up. So we didn't see any patients with strokes for weeks. We didn't see any people with heart attacks. And obviously people had those conditions, but just didn't present to hospital. And the patients that were in, I think, were very keen to not stay in too long, but were very compliant on the whole. We had the patients had to stay where they were. They were isolated, but they were very helpful.
So did you have areas of the hospital that were super busy and areas that weren't?
Yeah, there was whole wards and whole floors that were just empty, and it was airy. You would go through areas where there's lots of activity normally, and there wasn't anything. There was not a single soul. And then we started off with one ward, and then we had 2 wards, and then we had 3 wards with patients with COVID-19. So that was the area where the activity was.
So how did you transition from a sort of peacetime hospital to the pandemic model? How did you come up with the model in the first place?
And that was really quite interesting, because obviously people had made some plans, but on the whole, most of the stuff we made up on the hoof. So there was lots of regular short meetings with key members of the team, small groups, and would say, okay, how we're doing, what do we need to change, and then change it for the next day. So this really rapid changing from saying, okay, we only got one area in the emergency department to we're taking over a whole wing. We're now going to the 3rd floor. We're changing the whole layout there. We need some new doors in there. Can we have them for tomorrow morning? So that type of stuff we've never seen before.
How did those conversations happen though? Because surely there's a trade-off. There'll come a point where the demands of COVID would have impinged upon other demands of the hospital space, all the ancillary services, but also the other clinical services as well. So how did you establish, how did you change it, but also how did you establish a method by which to change it that everyone could agree on?
And there was a command and control structure for the basic running of the hospital, and then there was every day a huddle, a meeting of departmental leads. So the leader for the COVID team, the lead for the emergency department. And so we would discuss briefly where we were, how many patients we had, and then make decisions there and then on what needed to happen next. And I think it's important to say there was actually lots of people who had very little to do. So you had additional people that you could draw in. If you say, oh, look, I need a hand with this, there would have been clinicians and non-clinicians who would have been able to help, because lots of patients weren't there. So there were people who didn't have a clinical job at the time.
So when you say there's a command and control structure, is that something that is in place anyway for a pandemic, so it's clear what the line of command would be, or did that sort of have to emerge by itself?
And that was very much ad hoc. So that was decided centrally and then introduced, and certainly not something that we practiced for.
It was done centrally, did you say?
Yeah, so that was done centrally, and at organization level, at trust board level, This is not something we practiced.
And did that all go smoothly?
Um, on the whole, yes. I mean, so there was the major logistical challenges that you alluded to with the visors and PPE resourcing. But on the whole, because there was additional resource, because some workload was just not there, the agility, I think, was not planned but happened.
The agility and supply of these things is
No, the agility of restructuring your team and your spaces and just adapting and being agile, I guess.
So what do you think worked well?
So what worked well was the team working and the ability with the people who were running the service to say, this part is not working, we're going to change that, and we're going to change it now, or we're going to change it tomorrow morning. So to have ownership of those who are in delivering the service to do the service, that was definitely something that worked well.
Is there not a sort of trade-off in organization as well? So say at one extreme, you might have very little planning, so it's all firefighting, and generally everyone would agree that's a bad situation. But at the other end, you have too much order, so you have or endless squabbles over what an order might look like. So you can't for every conversation about how you're going to structure your workforce, how you're going to sort out your environment, all that sort of thing, or your services. For every discussion that you have about that is time away from the front line. So how do you balance that?
So normally these things take, and I think that there has been comments in the press and in literature. Normally those type of processes take days and weeks and months to agree on anything, but that changed. So people's mindset, and I think Juliette has alluded to that. People's mindset was just differently. So people were willing to compromise and to do pragmatic solutions, and so therefore a lot of the administrative processes that usually underpin this were shortened, and certainly a lot of camaraderie. So rather than saying, "Oh, this is somebody from another department, we're going to have a little argument now," and saying, "Okay, that sounds a reasonable suggestion. Let's try this, and if it doesn't work, we'll do something different tomorrow, and that's okay." So in that sense, I think in terms of efficiency of implementing change, really useful as a lesson, but maybe not with the same degree of planning and evaluation that you would normally try to use to underpin a process like that.
So you said maybe not the degree. So the fact that it wasn't so rigorous, but like very fast, it was a good thing.
Yeah, probably yes. Yeah. No, the other thing that is also unusual, we had, in a sense, in some areas, no resource constraints. So there was resource constraints with PPE, but most other things, if you wanted them, you could order them and somebody would actually get them. So if they were available on the market, you could get them, whereas normally there's long rounds of procurement and argument what is needed. And I think there was certainly a common purpose that certain things you didn't have the time to squabble about, and whether it cost a bit more or a bit less didn't really matter in the greater scheme of things, of being ready for this anticipated large surge in sick patients.
So regarding PPE, because I guess it's of interest because it's obviously physical product, design thinking, design processes, but it has obvious physical benefits, but also it's got quite an emotional element to it, because without it, it's a very fearful situation. So, and we know from the press that people are struggling with shortages of PPE.
Yeah.
So, well, the first question is a tangible one. Did you have enough? And the second is, were you ever afraid?
We were definitely afraid, and we weren't always sure how much stock we had. But at some stage, we were using stock from our nuclear industry, which is local, and so they borrowed us a stock that they had. So we knew that our own stock wasn't high. With regards to masks, again, there was a lot of agility. Basically, the local schools and universities started to print visors, 3D printing and fitting those out. So once they started doing this, we had enough. and then the supply chain caught up. But there was definitely days where it was uncomfortable to go in and be worried that we might not have enough stock. And you have to remember, I can probably say that. So my wife is a physiotherapist, and she would treat some of those patients and be really very close and have them cough. And you know that this cough has got COVID viruses in them, and so not to have the right equipment is immediately clear what that does. Yeah, and so that it was about saving lives with kit.
Where do you think design could have? What role did design play on the ground for you during that time, and how did it make a difference?
So one of the things that we approached you guys with and saying, look, we've got lots of documentation that we normally do, but we probably can't do this. And there was certainly the anticipation that we would have more patients in, and that happened to a degree, albeit not to the degree that was anticipated. So if we normally take in 50 patients, if we suddenly have to see 1,000 patients a day, how do we cope with it? So engineering of workflow and the way that we use documentation systems on paper to keep track of what is the safety critical information. And that was certainly, I think, design thinking, saying, okay, normally there's 8 people involved in getting somebody from the door to a hospital bed and properly admitted. Can we do that with 2 people? And what is the process and the information flow that we need to underpin that?
So do you think with that restructuring of the service, I guess the processes depend on your definition of service against process, but did that restructuring lower your daily use of PPE then?
Yeah, absolutely. And that was one of the wanted side effects, isn't it? So you got less people exposed to risk and you need less kit. And if you know that the kit is one of your strategic vulnerabilities, then that becomes life-saving.
Yeah, that's amazing. So I mean, yes, we've covered what it was like and the demands and the emotional demands of it all as well. Was there anything that didn't work well?
The modeling was, I think, flawed in so the amount of patients that we were expecting didn't quite match up. I'm not sure whether that could have been improved. And the fact that PPE wasn't available in abundance and there wasn't a pipeline to get it in very large numbers should we have needed it, that was certainly something that if you would do this again, if you wish, and which hopefully we don't have to, then those are the things that you would probably plan for. But it's also that if you now look at how we work, we realize how inefficient we are in many areas. And maybe this should really make us think harder of how people work, how we're working together, and how protective we are about certain roles and skills, and whether a better workflow would in fact be by sharing some of those skills and training people in different ways.
Interesting. So how do you feel that you're better prepared should there be, as we're looking likely, a second wave?
We're emotionally and technically better prepared in that we've seen this, but I'm not sure, whether people still got the stamina to do this all over again, because it has been exhausting, not just because of the hours. The hours were not necessarily that much more than I would normally work, but this fear of something could go horribly wrong every day you go in, and you come home and you hope you haven't contracted the virus. For how long can you do that? How resilient do you have to get to do that?
Is the confidence in the PPE key in all of that?
It's a really important element, yes. And having well-ventilated rooms and the ability to distance patients and staff in social areas and things like that, yeah.
Interesting. Well, thank you very much, Chris.
Thank you.
I think I would just like to say to all the attendees, if you've got questions, please type them in the Q&A. I forgot to mention that at the top. We'll address all the questions later on in this session. But for now, I'd like to just ask Lena to introduce herself. Lena Chiric, please could you just say a little bit about who you are and why you're here?
Yes, of course. I am an associate professor at University College London, and I am an expert, I guess, in where microbes lurk within our built environment.
And well, I guess the broader first question might be what were your thoughts when COVID first hit? Because it's fairly squarely in your area of expertise.
Yes, it is. I don't know. It was. I had a sort of mixed feelings of denial and, but also being resigned to what was to come. Actually, when it all started kicking off, I was on a secondment at Great Ormond Street Hospital, and I've worked with Great Ormond Street over the years on a number of different projects with their infection control team. And the reason I was there was because I was working on a project with them to look at how the different staff groups could work together better on infection prevention and control. So, how do the clinicians, they all have slightly different roles, but they don't communicate across them very well. So lots of different people participate in this. So of course the infection prevention and control team, but also the estates team, the clinicians, the nurses, the cleaners, and all. I think ultimately the idea was that I was there to observe and see how they work together and see what improvements could be made. So this was in February, I guess. So it was before lockdown in the UK, but I could see already, as during my time there, that they were very much preparing for what was to come, even though, the government was in denial and, pretending that nothing had to be done. It was totally fine. But the thing that I found the most surprising actually about the whole thing was that I've spent, years of my career thinking about how to prevent pandemics from occurring and, where to clean and how to ventilate. But I've never really thought about what the experience of living through a pandemic would be like, and the sort of totally different world that we now live in.
What surprised you about that experience?
Well, just that I didn't have the foresight to envisage it. I was just like, oh, just clean a bit more, it'll be fine. But clearly not.
So when you say you were working at Great Ormond Street at the time and you saw them preparing, what were they doing to prepare?
Lots of things. I mean, there were lots of meetings that I was not privy to at all, but some of the other things that were going on was just going around. This is something I participated in. We went around and tested the ventilation in the isolation rooms. So the ventilation is specifically designed to contain pathogens within the space, or to prevent pathogens from going out into the lobby, or prevent things from going into the patient room. So we went around checking those, and there was just, I think really I didn't see most of it, but there was a lot of administrative, wranglings about which wards would become what and which staff would go to where and so on. So yeah, I think most of it.
Did the transition to the sort of pandemic model? I don't actually know what they did at Great Ormond Street, but I'm guessing that they cleared out a space to deal with the COVID patients. Did that go well, or were you ending your secondment there at that time? Or
I was kicked out before lockdown happened because they could see that it was coming, and they were like, unless you don't need to be here, you are not going to be. So I wasn't there at that point. I know that they went through a few changes, but I don't think they were as major as in some of the in non-pediatric hospitals. I think they had fewer, proportionally fewer cases than hospitals that see both adults and children, and that those patients were not there necessarily for the period of having to deal with COVID-19 patients wasn't quite as long as in some other hospitals.
Just want to change tack to your expertise as a microbiologist. So for the lay people, such as myself, your field of expertise isn't just viruses, it's all the sort of microbes. But But are viruses, I guess, different or a different category in how they spread? How do viruses spread, and do we know anything more now than we're used to?
Well, I mean, viruses are physiologically different to bacteria and fungi that can cause infections, but ultimately the way that all microbes spread from one host to another isn't necessarily to do with the microbe itself, but with the contact that the human being has with microbe contaminated things. So it could be touch, it could be drinking or eating something that's contaminated, it could be inhaling droplets that have virus or bacteria within them. So there's been a bit of a debate, and I'll talk about that in a minute, but I think really now we know a lot more about SARS-CoV-2 specifically than we did at the beginning of this. And also it's, you know, depending on what the microbe is and what sort of disease it will cause in a human being or whatever other host, there are differences in how they're transmitted. So some viruses aren't transmitted through the air, some are, and so on. And you know, for example, for SARS-CoV-2, I don't think there's much in the way of evidence that if you drink or eat it, it is a problem, but if you inhale it, then it certainly is. So we know a lot more now. I think initially, remember, like we were all of the various public health bodies and governments were going on about hand washing. And of course, now we know that that's still important, but actually there's a lot more evidence now to show that respiratory droplets are a real, you know, a real possibility as a transmission pathway. There's still no like absolute consensus on this. Which I guess brings me quite nicely onto this whole debate about aerosol versus droplet, which has been rumbling on for months now. So aerosols are smaller, droplets are bigger. An aerosol can travel quite far because it's carried on air currents and it's light. But at the same time, because it's smaller, it will have fewer virus particles within it. Whereas a droplet is bigger, it'll settle more quickly because of its mass. So it, you know, it should settle quickly within the 2 meters or whatever, 1.5 meters, you know, it all varies around the world. But it will, and it carries more virus particles because it's larger. So what's been really tricky within this particular context is that we're debating about, is this an airborne virus or not? And there's this distinction, which I don't believe there should be, between aerosols and droplets, because ultimately they're on a spectrum. It's not like at one point an aerosol stops and a droplet starts. It's, you know, it's a continuum. So I'm glad that this debate is going on. And I think, you know, scientifically, it's interesting to have that. But what is difficult is that if it is, you know, if we are going to decide it's airborne, then that has real implications for care, both of patients and for protection of clinical staff. So that has been really difficult. And because of that, probably, you know, because there was a lot of denial about the possibility of this being airborne in the first place, perhaps we didn't protect our clinical staff as well as we could have done at the beginning.
Is from the point of view of PPE, going back to PPE again, is the discussion around droplet versus aerosol, is that, forgive the ignorance of the question, but is that impacting on the use of visors versus masks?
I mean, I guess it is to some extent, but I think visors, so a visor will protect you from large droplets that, you know, somebody might cough into your face, but it won't protect you from aerosols, which can be blown around and you know, might be influenced by the action of your own breathing and so on. So I think it's important to use visors and masks ultimately. because you're protecting yourself from sort of two different things. But having said that, masks, masks are, there's a variety of different types of masks, and there's more to that as well.
I'm thinking about the impact of what we do on how COVID spreads or behavior. So we've talked about the understanding of, is it spread via touch or is it spread in the air? I don't know if you've got any thoughts about, within those two mental models, what we can be doing and how we can design the environment and adjust our behavior accordingly to reduce the spread or make ourselves safe.
Yeah. I mean, I think from the point of view of airborne spread, the best solution is diluting it out of the air. So it means good ventilation systems that introduce a lot of fresh air and don't recirculate stale air around and around. But that's tricky to go around retrofitting all of the different spaces where people spend periods of time together. And then from the point of view of touch and surfaces and stuff, I mean, the solution is fairly simple. It's all about behavior. It's about us making sure that we're cleaning our hands regularly, and also about cleaning effectively. And I guess, I mean, this isn't really a design thing, but I think, and this is my personal experience and professional experience, both of cleaning within the hospital setting and cleaning within the work setting. I think ultimately cleaning is such an important job, especially within the hospital setting and especially under circumstances like these, but it's totally under-resourced and underpaid and, outsourced with a huge turnover of staff who are paid, a really low wage and expected to do a really physically and technically demanding job that, probably if they were to do it as they should or as their protocols say they should, they wouldn't actually be able to do physically within that time. So I think until we resource that and show that we recognize it as so important with bucks, that's not going to get sorted out.
Do you think that the response is purely financial, or do you think it's a degree of esteem and
Yes. Well, both. I mean, I think, the two go hand in hand, don't they? Really?
Yeah. I was also just thinking about, from one of our past projects we did years ago, which was design bugs out. Part of the research was shadowing hospital cleaners, and again linked to other projects that we did where we were assessing the risk from an infection control point of view. Cleaning surfaces, it's not obviously not the same as domestic cleaning. If your table's got a stain on it, you can scrub that stain out, but you can't see viral infections. At least I don't think you can.
No.
So there's actually no way, or maybe there is. It's a question. Is there a way of knowing if a thorough virus-killing cleaning has gone on and done successfully?
I mean, there is, but it means doing regular cleaning audits. And I think also I'm sort of going to push the conversation towards behavior and what design can do to help that. Because I think really from the point of view of cleaning and really from the point of view of behavior generally, I think we need to keep getting the message out. We need to keep training the cleaners, and checking whether things are happening, and not in a, oh, I'm watching you to make sure you're doing it right, but more in a, explaining to them why their job is so important, and that, cleaning this surface in this way means that one of these patients might not get some hideous infection and will have a better outcome. So I think there's a lot about communication and education, and the translation of evidence for the public and for different professions that I think design can really help with now. Because I think, we know that we should wear a mask, and we know that we should keep away from people, and we know all of these things. We know how to keep safe, but we're having a pandemic of bad behavior, both by our leaders and, you know, to some extent, consequently by the general public, because we've had, you know, bad messaging and, you know, under-resourced PPE, under-resourced test and trace. It's, you know, it's been a bit of a disaster. So it's all about now, you know, understanding what it is we need to do, taking responsibility for our own actions and for our, you know, our communities, and, you know, getting through this together, even if the powers that be have left us to it.
I wanted to just pick up. Thank you, Lena. I just we should probably move on to the sort of round table panel. But I just wanted to pick up on the last thing that you said, Lena, about working together, because it chimes with Chris, one of your earlier points about in the height of the pandemic. You said there was a really great sense of team working. So if someone came from another department, there was a sort of confrontation waiting to happen. Given what Lena just said about the sort of value of proper cleaning in clinical environments, are the cleaning staff considered part of the team in hospitals, or are they very much a breed apart?
I think Lena raised all the important points on this. Just from my own experience in the COVID unit, there was 3 colleagues who took it in turns to clean in the first few weeks that we were there, and there was real camaraderie there, and there was definitely the hierarchy started to melt away between junior doctors, senior doctors, nurses, doctors, clinical and non-clinical staff. But you know, if they are being employed by somebody from the outside, and are no longer part of teams as they would have been maybe 25 years ago, then that's a really structural problem, isn't it? Yeah.
Yeah, it's so fascinating, the different layers, sort of the political down to the physical product. To sort of there's so many different ways of tackling it, or you know, maybe a combination. I'm just going to turn to the Q&A that people have, the questions that people have been put in the Q&A. I'll just tackle them from the top, if that's all right. So
I've been hacking my way through some of them, so you know, I hope that the answers that I put in are okay, and I'm going to continue to look at those.
Okay, well, I'll address the open ones for now. I haven't seen the other ones, obviously. I'll just start off with Deborah Rozansky. With the growing rates of community transmission of COVID, what would you say are the main challenges for institutions like schools, community centres, libraries, or public transport? What lessons from the acute hospital experience can we apply to community settings? How can the public be involved in these design challenges? I don't know who wants to take that.
Yeah, the question below that has got a sort of similar theme to it, in around consumer behavior. And so whether it's staff or the general public is maybe less distinguished there. But you will see people standing quite close together. And you know, when I've got my COVID head on, I go, they shouldn't stand that close. They need to be 6 feet apart. So that's where I think design comes in, you know, to make those 6 feet visible. And certainly on the corridors in the hospitals, you've probably seen this. You've got these colored stripes, and you got one lane where you go up and one lane where you come back the corridor. So those type of things to make it visible what safe behavior might look like is probably really important. And that's everywhere. And it's not just hospitals. It's everywhere where people come together.
Yeah, I have to say, actually, looking at the positives, in my own sort of interactions in the regular community environment, I think it has been amazing the way different places, you know, cafes or pubs or shops, they've all taken it upon themselves, because obviously they know their environments best, and they've taken it upon themselves to best, you know, cope with the signage and a one-way system and all that sort of thing. I don't know if
Juliet something is to say something about that question as well, I think, is it? Or
sorry, say that again, Chris.
I'm wondering whether Juliet wanted to say anything about that question.
Oh yeah, I thought it was answering live, but please, Johnny, go.
No. I've said quite enough already.
No, I think it's quite interesting that a lot of people are asking what can be done through design, but I think it's important to link it to what Lena was saying earlier about the change of behavior. And I think there might be some design services, products, wearables that might see the light in the upcoming year or months, but ultimately they will shape our behavior around hygiene, around distance. So I think it's important to think of products that can adapt in the ecosystem of the millions of products that will be created. Because I think you mentioned this, Johnny, earlier. Hospitals weren't looking for 15 different types of like protections. They were looking for one that could be done easily and quickly and that could work. So yeah, I think it's interesting to see maybe in a couple of years' time how this will have changed our behavior through all the design products that will have come up.
Definitely, yeah. I think what is interesting is mapping the designer's intent for a product or a service or a digital intervention onto the actual behavior change achieved through that, and then past that to all the unintended consequences, because obviously no one's going to get it right 100% and there's going to be some sort of side effects. I'll just turn back to the questions just to make sure we tick them off before the session ends. The second one, oh sorry, no, they've moved because one's been addressed. Victoria, try that surname, Hoysiver. How can designers use the pandemic to change the consumer behavior in a more emphatic, holistic and behavior, as you say, Lena? How does that transfer in sustainable environments, services and products? That's a biggie. Lena, you were named, so you have to take that one.
Okay. No, it's true. It's hideous, isn't it? It's, you know, like every bush has a mask stuck in it, and there's a glove on every curb. Yeah, it's really awful. I don't know what to say, really. I think my personal opinion is that actually, if you can try a few cloth masks and find one that fits well and then get a load of those and keep washing them, I think generally they fit better than the surgical ones that you can chuck, that you just use once and then don't reuse again. And from the point of view of gloves, I think it's really actually wearing them as in a clinical setting, of course, but from the point of view of the general person on the street in a shop or wherever, I think it lulls you into a false sense of security that your hands are clean, and then you end up, you know, it's basically the same. It's just that you've got another layer on. And I've seen a lot of people, you know, in fact, I saw a bus driver around the corner from me on a break with gloves on, but eating crisps with those gloves on. And I just thought, oh my God, just, you know, no. And this is the problem with PPE, that if you don't use it right, it can actually be more dangerous than not using it. Because if I'm not wearing gloves, then I will be sanitizing much more regularly than if I was. So yeah, we really, I mean, this is a good design question. How do we move away from disposing of all of our various bits of PPE? And even, you know, some of the, I know there's a lot of new ventilator designs and stuff, and most of them are disposable. So we need to think about moving away from those sorts of materials and moving on to better, either non-disposable, reusable materials or at least recyclable materials.
Yeah. Thanks, Lena. They're coming in thick and fast, so I'm going to move on if that's all right.
Of course.
I've got one other addition to continue this, you know. So this bus driver probably has forgotten for a moment that he's a COVID bus driver and he's a bus driver. So this complexity of having this different behavior that you need to do over and above what you're normally doing. And so that's where one of the roles, I think, of design is, isn't it? To try to reduce cognitive load and make things so simple and obvious that even if you're under stress, you can still perform them reliably.
Yeah, I think you saw that in a microcosm in terms of cognitive overload in the messaging. I quite enjoyed, in a grim way, the signage on the podiums for every government press conference as it morphed from. They tried to fit in something portrait onto a landscape podium, and then they moved to a what was it? Sort of Bob the Builder kind of hazard style messaging. But I think, well, this is an opinion, but they sort of, the latest one seemed a lot more simple. What was it? Hands, face, space, which seems a lot like more considered, easier to remember, less cognitive load. I know that it comes along with a whole load of extra richness of detail and how to behave in whatever environments and circumstances. But you're right, Chris. It's people are evolving these things all the time. We're sort of reacting to a fluid situation. Must press on. I should just mention to the attendees that we're going to allow probably 10 more minutes. So we'll do a formal end at 5 o'clock, but the panelists agreed to stay on for another 10 minutes just to see if we can address all of these. And thank you to the panelists. There was one that's out there, yes, Chris, this one, I think it relates to what you said earlier. This is from Kulbir Bakker. I am a frontline worker in a senior living here in Canada. Unfortunately, we have never been a part of any decision taken by our organisation, and it feels mentally exhausting. What would you say about including the frontline in the decision making and the implications on their mental health?
I think that's a really good question, Kulbir, and so empowering and agency has been definitely one of the things that helped us to cope. And so having daily conversations in the team, how do we do this? Are we doing this right? What do we need to change? And as I said, in a very positive way, eroding hierarchies and having our juniors wrote some of the protocols, so basically, whoever has got the idea can take it forward and enabling people. Now, I'm still struggling to see how that would pan out in very large teams. So how do you create ownership and in potentially a very diverse discussion? But definitely, it's one of the ways that we support resilience in that we give people ownership of processes or parts of processes.
Did it help? I remember, Chris, you showed me, I don't know if you have it to hand, but you had a visual of how you had redeployed the environment. And I wondered if, aside from the brilliant design of that visual, showing everybody in the, thank you, Chris. And if you could skip to that part where there's a layout of the clinical space. Well,
that's the clinical space. And so as we're going through the different phases of this, so you can see more and more. So on the left, you got the COVID area, and that's in red. And as we're going through the different phases, more and more becomes red till in the end, everything is red. That's what you were alluding to, isn't it? So that's how we normally operate. So this is the majors area, resuscitation, minus, and this is an area for clinical decision making. And so we started off, this was our initial COVID unit where we hold up for the first few weeks with our team, and then it spread further and further into the hospital.
The point I wanted to make about this isn't necessarily the intricacies of the design, but the fact that there's a design in and of itself that you can then agree the tiered nature of. Was that quite helpful in spreading the message or allowing people to buy into it? So you're all looking at one bit of paper and you can all say, I agree with this, I don't agree with that, but at least there's something to be looking at rather than, a sort of edict from on high.
No, absolutely. And the logistic challenge, making that visible to everybody in the organization, I think in that sense, Juliette, your challenge of, saying we're going to have a new department and stuff needs to be somewhere. So we need to put the map of that, but how does everybody access this? And ideally that would be in an electronic environment, but I think our systems are not really designed to transmit that information in real time.
Interesting. The next one, Marianne Noble. Actually, I might let Juliette have a look at this one. I am interested in the communication of invisible dangers, how to visualize the invisible, such as COVID-19. Do any of the panelists have any good examples of this? What role could the designer have in visualizing COVID itself? Juliette, as our information designer extraordinaire, I don't know.
You're basically asking me to answer a brief, 1 minute from the end of the webinar.
Go for it.
I think it is tricky because it would be interesting to see how, actually, I was looking at another question that comes later about how the viruses shaped the pandemic in how the viruses of the 19th and 20th century was shaped like the new architecture, like the new century architecture. Would be interesting to see how in the past this has been represented, because I think you always end up falling back into stereotypes when it comes to those kind of messages.
Yeah.
And at the same time, and this is something we've seen while working into office spaces that have to be like rearranged during the pandemic, you don't want to fill the space with alarming messages, such as like big red circles being like, stay 2 meters apart from your fellow colleague or whatever. So it is, how do you remind that there is danger without creating an environment that feels dangerous? And that's a very tricky one, I think. I don't have an answer right.
I'll have a little bit to say on this. We've been working on a project with Transport for London because a large number of their drivers didn't do very well out of COVID. And one of the things that we did actually was one of my colleagues is an expert in computer simulations of airflows. So what we did was to use simulations to see how the breath of a passenger who's just got on a bus and coughed, how that might end up within the driver's cab. So I think it's a combination. I think design is there to implement the evidence, I think. So it's a combination of maybe using those computer simulations, which are actually not that accessible, and give you a gazillion equations and stuff, to translate that into something that's useful for the general public. And also, I think, translating, we did a study again at Great Ormond Street where we used just like a simple piece of DNA as a surrogate for virus spread, and we put it on a bed rail and then swabbed a load of surfaces within the ward later that day, and then the next day, and the next day, and the next day. And that shows you how quickly things can spread just because of touch. And we can use designers to then, form an animation about how this spread to translate the data, which is actually quite inaccessible, into something useful.
I seem to recall, that's interesting. I seem to recall I think it was a Glasgow School of Art. I might have got my Scottish institutions mixed up, but they did a project which was, I think, a augmented reality thing where you could go into I think it was a private hospital room, a single patient room, and you could see sort of the bugs living on the handle of the taps and so on and so forth. That's the only thing I can think of directly trying to visualize the bugs, but obviously they didn't have any sort of filter which actually showed bugs. It was more a sort of theoretical exercise, but very useful in and of itself. I'll just press on because I know we're short even on our allotted length of time. So Shamil Hajar, one of the design industry that was badly hit is in events and exhibitions, and it's among the last ones to recover. How do you think we can foolproof such industries in the future? Wow, events, exhibition spaces, what can be done from a pandemic point of view? I don't know if any of the panel wanted to address that one. Well, I mean, there's nothing in terms of specific design of layout of exhibition or event spaces, but I wanted to pick up on a previous thing that I think Juliette said, which was talking about.
Well, it's interesting. So certainly, we're at the moment in a webinar, isn't it? And it's clear that most of the conferences have moved swiftly online, and we've hosted events where we normally get 50 to 60 people, and we suddenly had 180 people with international speakers. So I think some of this has already shifted. So the physical bit, I'm not so sure. The little drink that you go for afterwards, or the coffee that you go in the break. I don't think we've managed to find platforms that translate the social interaction in the same way. But the stuff that transmits information has amazingly moved at a pace that was unimaginable even a year ago.
Yeah, I agree. So the very sort of human social element is very difficult to replicate. I just wanted to pick up on something that Juliet was saying about a previous question about previous environment design because of past pandemics. We did a piece of work with York University about architecture in pre-antibiotic times, architecture now in antibiotic times, and then speculating on what post-antibiotic architecture might look like. And that was really interesting. They were talking about the clinical space. So in the very early times and the sort of Victorian times, there was a thought about daylight. So Victorian hospitals had huge windows and then lots of ventilation, fresh air. In fact, people brought outside into a garden to recuperate. And then we moved to an antibiotic sort of realm of architecture where patients have their own rooms, and that's what we see now. People are trying to be isolated. The best example of a post-antibiotic, I think, was I think it's in Malmo in Sweden. I might have got the hospital itself confused, so forgive me. But the whole hospital is built as a sort of rotunda with patients' own rooms around the outside, and patients just stay in that room, and then the inside is served by clinical staff who then enter each door from the inside, and then the patients themselves receive their visitors through an external door. So when you're visiting the hospital, you don't go down any corridors or anything like that. I think you just go straight from outside into one room, and then that's it. It's interesting, sort of, it's the only one I can think of that's a sort of implication for antibiotic use, and I guess for also infection. I'll just quickly move on. Okay, we've got 3 outstanding ones. I'll just read them all off, and then we can sort of discuss them together. Maybe we can design a very exaggerated workclothes for doctors. Face, space, hands sounds more memorable to me. I wonder if they use a test of the various ways of combining these words. And hello, Lena, are planes safe in current times? So maybe backwards, Lena, talk to us about planes.
I will talk about planes briefly. The ventilation on planes is probably as tightly regulated as any indoor space, other than maybe operating theatres and clean rooms used for the production of pharmaceuticals and medical devices. So ventilation-wise, great, but it could be that you're there for quite a long time and you could just be unlucky and be next to somebody who's infected. So I would, you need to stick with the usual advice: face, space, hands, face, space. Yeah, definitely cover your face. Don't touch too many things. Sanitize. Keep away from people as much as you can.
Thank you. Chris, have you seen any innovations around clothing for clinical staff?
No.
Can you suggest anyone?
And I mean, can I just say, I think the people who are probably at the highest risk are not doctors. They are nursing assistants and people who are working for prolonged periods of time in the bed space with the patients. And they are the ones that probably need the biggest protection. And no, I haven't seen anything except for, the stuff that everybody's seen, the usual PPE. And there is a question on the whole, whether you could make, that goes probably to Juliet, clothing a bit scary so that people stay away from you. Or maybe make it smelly. How about that?
That's great. Well, I wish that would be our ending one, but we've got last thing. Straw poll, what order would you like? Face, space, hands, space, face. What do people think?
I prefer the face space at the end. I don't know why, but I think in answer to your question, I don't think anyone consulted anyone. I don't think there's much consultation going on, or maybe there is consultation, but then ignoring of what is what the advice is.
Okay, well, that concludes all of those answers. I don't know, I did ask you 3 to conclude. We're at 10 past now, so I don't know if you'd be able to conclude with a final sentence, and then I'll draw this to a close. Juliet, I wonder if you have any final thoughts.
I am personally hoping that there will be more projects like this, not in the sense that another pandemic will hit and we'll have to do this again, but there will be more collaboration that are maybe more fast-paced, because I think this kind of project has triggered many questions and probably some unexpected solutions, hopefully. So yeah.
Thank you. Chris?
Yeah, I second that. I think COVID has highlighted problems that were there all the time, and the need for innovation. We all known about it, but now suddenly it's obvious. And I hope that regulators and those who are purchasing have got the wisdom and insight to find better ways to get the design that we need authorized, tested, and implemented.
Thank you. And Lena?
Yeah, we're in for a bit of a bumpy ride over the coming months. So I think it's really important that we work together and we collaborate and pull together and listen to each other instead of, having these divisions which are not helping anyone. Because really, I think that's the only way that we'll get through this. So I think both on a personal and professional level, we need to pull together and work together to beat this virus.
Thank you, Lena. That's a great note to end on. I'll just finish by sharing my screen just to remind everybody that today was just one in a series of talks that are lasting all week. So we have 2 tomorrow. The first is on agent diversity at 2:00. Second at 4:00 tomorrow on inclusive design for social impact. Then on Thursday at 4, we have inclusive design, business value and pathways. And we'll finish the week on Friday at 4:00, Creative Leaders Circle, a call to action. So thank you all very much for joining. I hope you got as much out of this session as I did. But yeah, a pleasure. And thank you to all the panelists. So thank you and goodbye.
Thank you.
Having us.
Bye-bye.
Bye.